where we might change from a clinician to a patient perspective. And we were very keen at the EPA to try to understand, is it a paradigm shift? And what does that mean and represent? Why did we focus on this topic? There are different reasons for that. The first one is for the ethical reason. We know that patients are at the core of the process of treatment, and they should have their voice and being involved in this decision and the way we treat them. And having on board Gamian and Ufami, for which we are very happy for that, they also push for this idea that we can increase the quality of our indicators, looking at the assessment of patients. The second aspect we thought was important is the shared decision-making process, because we all recognize that it is associated with a higher efficacy. And so getting on board patients for assessment means different ways of treatment with a higher efficacy. So it's also important in our more clinical aspect of the treatment. The third point is about the clinical impact. If it's an opportunity for a different type of care, it means maybe higher efficacy, better results, and that change might be assessed also through this aspect. And the last one, of course, is an economical aspect. We know that the treatment usually are very expensive, especially hospitalization. So if we change a little bit our way of assessing it, maybe it would be in a way where we have better compliance to what is expected by patients, and then modifying a little bit the way we are treating patients. And that would be maybe a way to make some saving, which is an important aspect in this crisis period. Okay, so we thought that it was a very nice topic, but are we ready for this kind of change of our indicators? If we see all the potential benefits, are there some limitations? And all those aspects are going to be discussed today because they probably represent a very important topic that we have to share a lot and interact a lot, and also capture all your input in order to see if we are really on the same line. So thanks to all stakeholders, the representative of the European Union Commission, the OECD, the WHO, and the stakeholders of all the associations we are working with at the EPA on an everyday basis. They will participate, they are present today, and it's very nice that we can have this kind of discussion. We will have the opinions of a lot of international bodies of these indicators, and I will share some of the very preliminary results of the EPA Ambassador Survey for which you probably received the link to fill in, about the shared decision style. Are we already giving some place and space for patients in our assessments and in our decisions? That's the point about this year's survey, and you are able, and we will have time for that, fill in the survey also during this aspect. Don't forget that we have time for question and answers. We really count on you to ask questions to all those stakeholders that will be present today. And that's really the nice part of the forum where we have a lot of interaction. So I will conclude the day, giving the word to Peter Falkay, who will be the president of the EPA in a couple of hours, I would maybe say minutes, and he will take the lead for the organization of the second half of this forum. So without further ado, I would like to give the word now to John Ryan, who's giving the keynote address from the EU Commission and who's Director for Public Health. So thank you very much, and I hope we're going to have a very lovely morning. Thank you.
Thank you very much for inviting me to speak at this event. I have no disclosures to make in respect to this conference. Following in the footsteps of my Commissioner for Health and Food Safety, Stella Kyriakides, who delivered the opening address at your forum in July last year. At that point in time, member states across the European Union had experienced the first wave in the COVID pandemic, and the huge impact on the physical and mental health of our citizens was already building up. Commissioner Kyriakides noted that the pandemic had put the issue of mental health in the spotlight and shared her commitment to work with member states and all relevant stakeholders to reduce the pandemic's psychosocial impact. In the 2018 State of Health in the European Union report, we had a specific chapter on mental health, This gave us a good indication of the considerable challenge we already faced at that time. As many as 84 million people across the European Union were affected by mental health problems, with over 48,000 people dying of suicide in 2017. The report also quantified the financial burden of mental health across the European Union. We spend over 600 billion dealing with the consequences of mental ill health, which is more than 4% of GDP. Not surprisingly, that report made a strong case for promoting mental health, preventing mental illness, and improving access to treatment for people with poor mental health. The following edition of the same report, the 2020 State of Health in the European Union report, came out in autumn last year and also presented data on health system resilience against the backdrop of the COVID pandemic. It noted that the COVID pandemic and the subsequent economic crisis have led to a growing burden of mental ill health, with emerging evidence of higher rates of stress, anxiety, and depression, and with young people and people in lower income groups at increased risk. We know the mental health challenge posed by the pandemic is getting more and more complex, requiring us to find answers to its immediate and long-term consequences. We need all hands on deck, and organizations such as yours and its members have a role to play. To support stakeholders, the European Commission has set up a network on our EU health policy platform so that organizations from the health and social field can exchange practice and knowledge related to the mental health impact of COVID. Currently has 80 participants, including a representative of your association. Your president and the chair of this session, Professor Philip Gorwood, was one of the speakers when we shared the first results of the network's efforts during a webinar last October, addressing the mental health needs of health and social care workers in particular. On May the 10th of this year, we will be taking a further step by organizing a high-level conference on the mental health impact of COVID-19. This will be a major event bringing representatives from member states, the European Commission itself, the European Parliament, WHO, and key stakeholders together. I'm pleased that your association has agreed to contribute to the event, and I'd encourage all of you to attend this virtual conference and to contribute. Mental health is not, of course, a new issue for the European Commission. On the contrary, the European Commission has been supporting efforts in the field of mental health for over 15 years, with each new activity building on the previous achievements. These include, for example, a European Pact on Mental Health and Wellbeing from 2008, a first joint action between the member states on mental health and wellbeing, which ran from 2013 to 2016, a European Framework for Action in 2016, and a 2018 EU Compass for Mental Health that collected policies and good practices. The nearly 40 good practices gathered via these processes were incorporated into our best practice portal. Over the next few years, and with the financial support from the financial instruments of the European Union, we hope to invest over 7.5 million euros to implement some of these best practices in member states that have expressed an interest. So I'd just like to highlight a little bit about this process. The Commission's work on non-communicable diseases and mental health builds on international frameworks such as the UN Sustainable Development Goals and, of course, the 9 voluntary targets set by the World Health Organization. Our efforts focus on supporting and complementing member states' policies. Within this context, mental health is being addressed as a matter of priority in the Commission's support to member states through the implementation of best practices. we have a specific committee of member states looking at this topic. It's called the Steering Group on Promotion and Prevention. And the member states' health ministries not only prioritize mental health for this purpose, but also identified specific best practices which were of interest to them. So the top 3 best practices that we're going to finance this year will be a mental health system reform focusing on strengthening prevention and a client-centered community-based services developed in Belgium. The idea is to take a localized or national best practice, evaluate it, and then propose it to the member states for scaling up. A second best practice project originating in Austria, which we hope as well to scale up over a wider number of member states, concerns suicide prevention. And the third project developed in several previous projects is a stepwise intervention program tackling depression. So 3 subjects, 3 different best practices, 3 different groups of member states, taking evaluated best practices and scaling them up using European Union finance. That's how the procedure works. I'd now like to turn to your forum more particularly and the challenging issue of quality indicators for services and care. In Europe, as you know, health systems share the overarching values of universality, access to good quality care, equity and solidarity. These themes play a key role to ensure good health in the population and are indispensable to the sound functioning of our society as a whole. My colleague Maya Matthews will speak later on this morning on the issue of national health system performance. It's not always easy to untangle the effects on population health of broader societal factors of coverage or the functioning of the health systems themselves. Good data and good indicators are absolutely needed, given the importance and the complexity of health systems. Moreover, internationally standardized and compiled data allow for mutual learning between the member states' health systems, a process that helps to improve health systems performance for all citizens across Europe. In that regard, the Commission fully supports the importance of data and indicators measuring the performance of health systems when it comes to key dimensions such as healthcare, accessibility, effectiveness, and resilience. I'd like to mention here in particular the work which we're doing with the OECD in relation to patient-reported health indicators, which I think is an important input into the consideration of quality and care from the patient's perspective. Data and indicators are therefore essential tools to monitor the health status of our population and possible related inequalities. Let me mention that in the recently adopted cancer plan, the European Cancer Plan, we proposed the launch of a cancer inequalities registry. Now, this is a topic which is very relevant for cancer, but I imagine it might also be very relevant for mental health issues, and therefore I leave that idea there as something which you might like to discuss and consider as to whether we need to be more proactive in identifying inequalities. The idea would be not simply to have another set of data, but to use those data on inequalities to identify areas for improvement and then to identify funding instruments which could be used to actually implement change. So I think the topic of your forum is very timely. I look forward to learning more about the outcome of your reflections, and I encourage you to actively inform the Commission of your points of view and your proposals. And we'll very certainly be very interested in having this dialogue with you and with other mental health stakeholders across Europe. Thank you very much, ladies and gentlemen.
Thank you for very nice first presentation, and don't be afraid, you will have some feedback. And especially this forum is a way to collect all important informations and viewpoints. And we will try to gather all these to get some clear message to improve all those different aspects. So let's go now to the two next presentations about how do international bodies address benchmarking indicators for mental health. We will have the OECD and the WHO. And for that, we will begin by Catherine de Bienassis, who's going to talk about mental health performance in Europe and benchmarking indicators. Catherine is the Health Policy Analyst Organization for Economic Cooperation and Development. Thank you.
Thank you very much. And first, I want to thank the EPA Forum for inviting me to speak at today's meeting. I'll begin by saying that I have nothing to disclose. So OECD countries are moving away from measuring societal progress solely in terms of economic growth and are shifting towards improving value of public spending so that it truly enhances individual and societal well-being. In the health sector, we've traditionally looked at outcomes related to mortality, morbidity, and disability in order to assess the performance of health systems. And this has relied on other indicators that are easy to measure, such as physician visits, numbers of procedures or tests, or hospital days. And while this is incredibly important information, health systems in OECD countries can complement this with investment in patient-reported outcomes as an avenue to achieve more value-based care. Too often, patients receive care that's not tailored to achieve their individual interests or outcomes that they prioritize, such as better managing of their symptoms, improving their quality of life, or achieving their personal goals. And this leads to low value care for health consumers. Patient-reported measures are a major opportunity for patients, clinicians, and policymakers to better understand health system performance. But we still need a comprehensive and comparable system of measuring these patient-reported indicators to get a sense of what the health system is actually buying from the investment. So that's why at the OECD, we're focusing on international collaboration to enhance patient reporting, patient-reported indicator reporting in mental health. So before zooming in on a specific aspect of mental health benchmarking, I'd like to zoom out a little bit. Currently, the landscape of international metrics for understanding mental health and mental health care is just that, it's a landscape, where indicators can be found in a variety of work programs and thematic programs, even in the OECD. So I'll start with our OECD health statistics. Our databases currently report on over 20 mental health or mental health systems related variables, including mental health related causes of mortality, potential years of life loss, numbers of physicians, hospital beds, and hospital discharges, all available in terms of diagnostic categories, hospital average length of stay, pharmaceutical consumption and sales, as well as some healthcare quality and outcomes indicators. And these would include excess mortality for those with severe psychiatric conditions. Next, we have a stream of work on mental health benchmarking. This work is focused on understanding and measuring system performance of mental health systems and looking to identify policies to strengthen performance. And the final report for this work is expected later this year. We also have a stream of work related to mental health, employment, skills, and youth. This work looks at mental health and its impact on worker productivity and the economy, and works to improve strengthening integrated cross-sectoral policy. And then we have work on the patient-reported indicator surveys. This looks to understand health system performance through the patient perspective, and it's this aspect of work that I'll be speaking to primarily today. So why the focus on PROMs and PREMs by the OECD? And I'll just add here that I'm really looking forward to today's discussion and the roundtable later today on the same topic. We know that their use of patient-reported measures in mental health care is still pretty nascent. but there is an increasing body of knowledge and expertise. This also means that there's been a proliferation of patient-reported measures of quality of life, experience, and health status in mental health care over the last 20 years. But with so many measures being used, lack of harmonization makes it difficult for providers, health networks, and health systems to compare their outcomes and learn from each other. Some European countries, such as Norway, the Netherlands, Denmark, and Belgium, are really leading the way with national or regional assessments of PROMs and PREMs in mental health. But this is really the exception and not always the rule. So despite the current lack of infrastructure, existing patient-reported measures can provide insights to potential problems and opportunities for improvement. The data that I'm showing here is from the Commonwealth Fund that shows that those that report having a mental health problem are more likely to report that their health has kept them from working full time or has limited their daily activities. And these findings are consistent for all the countries for which we have data. Similar findings also from the Commonwealth Fund survey data asked people whether they received conflicting information from healthcare professionals. The subgroup of people who reported having a mental health condition also reported substantially higher rates of receiving conflicting information. So while population level survey data like that from the Commonwealth Fund is an excellent start, there's been a push for better international benchmarking for POMs and PREMs that assess quality and outcomes, specifically in the context of mental health service provision. So since May 2018, the OECD has been working with patients, clinicians, and policymakers to develop mental health PREM and PROM data collections that will enable international comparisons and facilitate cross-country learning. So in particular, the OECD has coordinated a working group, which is currently chaired by Denmark, that has developed PREM and PROM data collection standards in mental health care, focusing on PREMs related to the topics of respect and dignity, communication and relationship with the healthcare team, shared decision-making, and then PROMs related to restoring well-being and social function. Selecting PROMs and PREMs from the wide spectrum of available tools is not easy. So I'd like to highlight some of the questions that the working group worked through in identifying patient-reported measures for benchmarking in the hope that these would be helpful for any policymaker, healthcare administrator, or clinician in selecting PROMs or PREMs for mental health care or in other healthcare settings. These relate to the scientific acceptability of the measures, whether to look at generic or condition-specific tools, the involvement of service users in the development of the PROMs instruments, whether the PROMs can be easily integrated into existing systems of care, the respective burden of the data collection on both patients and care providers, and if the information generated is going to lead to actionable results, both for clinicians, for health systems, and for national policymakers. So initial results from our pilot data collection will be available this spring. We are still currently in the middle of the data collection process, but I'd like to highlight the items that we're collecting information on, both for patients receiving psychiatric inpatient services and those receiving mental health services in the community. The working group identified 2 streams of items related to well-being. These include the OECD assessment of subjective well-being items and the WHO-5, and then the group has selected 4 items from the Commonwealth Fund related to the 3 priority PREMs domains. I'd be remiss if I didn't take this opportunity to recruit. So if your practice is currently collecting data on any of these items and you'd be interested in sharing your data with the OECD, please don't hesitate to reach out to me. It's a pilot data collection, so we are starting with specific facilities as our target, and so we'd be very happy to hear from you. In addition to this work specific on mental health, I'd also like to highlight our work for developing the Paris survey for patients living with chronic health conditions. This is currently underway, or it's being developed in 20 participating countries. And we'll look at patients that have one or more chronic health conditions and are living in the community and are primarily managed in the primary care setting. This is a very high-level framework to identify the items that we'll be collecting in this comprehensive survey of both patients and their care providers. But I just wanted to highlight in particular the domains related to patient-reported experiences that will assess items in the domains of access, comprehensiveness, continuity, coordination, and safety, as well as people-centered care. And then we're also looking at patient-reported outcomes related to symptoms, functioning, self-reported health, and health-related quality of life. And as I said, the field trial for this will be occurring in the second half of this year, and the survey tools have just recently been finalized. So if you're interested in learning some more about our specific work on Paris or for the mental health related work stream, please refer to these resources. And please don't hesitate to reach out to me. And thank you very much again for the conference organizers for giving us the opportunity to speak at your meeting today. Thank you.
Thank you, Catherine. Very interesting. And definitely, if you are interested to participate into this movement and collection of data, please do so and contact Catherine, because we need large comparison between countries and different settings. Very nice. Thank you. Let's go now to the next presentation from the WHO Global Mental Health Atlas and other core indicators in this area. So Daniel Kilsum is a program manager for mental health from the WHO Europe. So thank you very much, Daniel, for your presentation.
Great. Good morning to you, Philip, and everybody else joining the EPA Forum this morning. Great to be with you again and to make a contribution on this topic, which is of particular interest to me, actually, on quality indicators in the area of mental health. And I'll give a kind of, yes, quite a global perspective on this and tell you something about what WHO has been doing in this area of indicators and measurement for well, a couple of decades, I suppose now, and also talk a bit about the broader landscape in which we're now in. So I have nothing to disclose, and the questions that I wanted to mainly touch on here. First is a kind of a grounding question about what is it that we really want to monitor, why, and who for. I think that's an important question to ask, because there are, as you already heard from Catherine, that it's a very complex area, and there are so many entry points where we could benefit from better information. So thinking a bit about who's it for, what are the levels of measurement that we can consider is a first question. And then the second one is to cover some of these indicators that are already being collected on a global basis. So what I mean by the who wants to know what, I think this gives an indication of the different levels on the right, moving from the actual individuals and families who are affected by, let's say, mental health conditions or psychosocial disability, as Katrina was just saying, about trying to better capture the outcomes at that level, through to district level or subnational level indicators up to national and indeed international. And you see on the left, you know, a whole range of potential stakeholders who might want some information, going all the way from, let's say, high-level policymakers and planners and regulators, down to insurers or payers of services, the national statistics offices, of course, researchers and evaluators. But then if we keep coming down, then thinking about the managers of services, the providers of healthcare programs, individual workers themselves, psychiatrists and nurses and so on. And also, of course, as mentioned, service users, families, and civil society more generally. So it's a huge range of stakeholders that we need to somehow satisfy and try and provide and generate useful information. Some examples of what I mean here cover things like the existence of policies and laws or health expenditures at the national level. Perhaps the suicide rate is very important, and it's also a Sustainable Development Goal target. So this is an important indicator at a global level, right down to the issues that were just being talked about at the individual level about, for example, the use of services, the uptake of services. What is the satisfaction with the services that have been used? And of course, most importantly, the outcomes of services. Did they actually provide benefit? So let's move to the second part. And I want to say something about this long-standing project now called WHO's Mental Health Atlas, which some of you will have to be familiar with. It actually started back in 2001, exactly to address the lack of good quality mental health indicators internationally. And it's been running since then, more or less every three years, certainly in the last, since 2014, every 3 years. And of course, this is pitched at quite a high level. So we're talking about the top end of what I was showing, the national and the international levels of data collection. And it's covering things like policy, legislation, and governance mechanism, and stakeholder collaboration. Collects information on both human and financial resources, sort of expenditures, also numbers of mental health workers in countries, then down to the actual availability of services, so numbers of hospitals or outpatient centers, community-based centers, and so on, and numbers of people seen through those systems. And finally, ask some questions about the actual information systems themselves. So what is the quality of those systems? How is data collected, and so on. So this has assumed more and more importance, I would say, in the last few years because of this WHO Comprehensive Mental Health Action Plan, which went from 2013 to 2020 and has now actually been extended by the World Health Assembly to 2030. So we've updated, in fact, some of the targets and action plans, because obviously we need to go further in the next 10 years. And this Mental Health Atlas survey is actually the main mechanism for collecting data to track the progress towards the objectives and targets of this plan. So it looks a bit complicated, but over on the left, you've got the main objectives. There's only 4 of them, 4 main objectives of this global plan. And each of those has 1 or 2 global targets, which is the second column, and some of the indicators that would be used to measure progress towards those targets. And then you all might see this perforated red line, which is around the second objective, around the provision of services. And there we needed to unpack, and these are some of the key indicators that are collected through the Mental Health Atlas exercise. So these are essentially service development indicators dealing with some of those issues around resources, around the availability of services, aspects of inpatient care, for example, the proportion of admissions that are involuntary, issues around service continuity and social support. So this is a big exercise, I can tell you. I've organized one in the past, and this is global. And so we have 194 member states. In the last couple of exercises, we've managed to get up to about 175 countries reporting on these data. So these are summarized not only at global and regional level, but also country profiles for each of the countries that submitted a response. So you can find those on the WHO Atlas website. So that's a little bit about Atlas, and just in the last couple of minutes, I want to say something a bit about the broader context in which we're now in, and I'm particularly talking about the Sustainable Development Goals, which Joel mentioned in his opening speech, but also, of course, the COVID times that we are living through. So I think what this summarizes is in the middle, you've got the kind of indicators that I was just talking about, which essentially capture aspects of mental health system capacity, dealing with how much money is going into them, how are they organized, what services are available, and so But really, we need to do more, and we need to look backwards or upstream as well as downstream and go outside the box. So on the left-hand side, essentially, the performance of a mental health program or a mental health system is to some extent influenced by some of these broader determinants, which might be as broad as the political or economic situation in a country, or even the model of social choice in a country. That may have implications for example, how much resources or priority is accorded to mental health. So a range of these mental health determinants on individuals and population, but also mental health system determinants. And then on the right-hand side, you've got the mental health outputs or outcomes of a system. So this would be very much coming back to what Catherine was just saying about the patient reported outcomes, extremely important. So issues around, for example, functioning, so that we're able to see what is the outcome of services, but also better measurement of things like financial protection and economic outcomes. Just saying something on COVID-19. So of course, there was a very sudden and urgent need to get a better understanding of what was going on in countries last year. So WHO organized, as part of this latest Atlas project, a special module on COVID-19 to get some information from each of the countries about what they were doing. Do they have MHPSS as part of the COVID-19 response plans, for example? What's been the impact on services, and a number of other key indicators, and that's now been repeated in a follow-up pulse survey. So you can see the publication there. Please go and have a look at it if you're interested. So I'll just finally mention a couple of issues, a bit like Catherine did, about some of the questions and issues I think for the forum to discuss as well. Part of it is my first point, which is around the need for conceptual clarity and what are we actually trying to measure and why, and what is the utility of that information. So what use is made of all of that data that is collected, and can it, for example, be usefully informing improvements in routine care? That would be great, and I think a lot of the time that people don't have the time or the motivation to actually use all the data that is available to them. And then some of these issues around the normative versus pragmatic needs. So relevance and validity, yes, might be high, but the feasibility of collecting data might be low. And I know OECD, and WHO have, struggled sometimes, to identify indicators not only very important for member states, but also data that can be reliably collected and reported. And just on that final point about the international organizations, there are several, efforts going on and obvious need for close synergy in those exercises, so we're not imposing too much data collection and separate parallel data collection requests on countries. So with that, I'll pass back to you, Philip. Thank you very much, and looking forward to the discussion.
Thank you, Dan, and definitely a good idea to give as a final word the importance of synergy, because this is exactly what we need, working together in order to find these how to tackle this very complex issue of how should we assess the quality of care that we are providing. Thank you very much. So now let's go to the second part of these indicators in real life context topic, and we will begin by using indicators for an effective response to the COVID-19 pandemic by Florence Button, who's a senior scientific officer and topic lead in psychiatry in European Medicines Agency, the EMA. Thank you.
Oh, hello. Can you hear me?
Yes, perfect. And we see the
sorry for that. There was a slight, sorry.
Just said good morning.
Yes, yeah. Good morning, everyone. So thank you very much to EPA for inviting EMA this morning. So I'm myself, Florence Butlen. I work at EMA, and today my talk will be about using indicators for an effective response to the COVID-19 pandemic indeed. So I have no disclosures. So briefly, what I would like to touch upon this morning is, first of all, giving you an outline of the situation. So what we have seen in this COVID crisis is in terms of mental health issues, and who seem to be the people most at risk during this crisis and afterwards. So then a few thoughts about what we could do together at EU level and what would be the advantages of such coordinated action in the EU. So first, I mean, this crisis has been quite hard on people and on people's physical health, but also what we have seen, it's increasingly and really substantially soliciting the mental health resources of people. And either it is an emergence of new psychological, psychiatric symptoms or the exacerbation of pre-existing mental health conditions, what we've seen overall is really an increased need for mental health care. So the symptoms can be quite various, from an overall sense of ill-being and moral suffering with very unspecific symptoms such as fatigue, fear, irritability, and also some proper psychiatric reaction requiring a rapid management of patients. So notably an increased risk for depressive disorders and anxiety disorders, but also in terms of addictive addiction, an increase in alcohol consumption and substance abuse disorders. So also suicidal ideation and behavior have been reported as a substantially increase in the population. So there are different groups and not everyone is affected the same way. So people with pre-existing mental health care are certainly to be monitored and have presented a number of manifestations. Healthcare professionals have been under a high pressure, unprecedented stress with reaction that could be quite unspecific again, like sleep disorders and anxiety, but who are also to monitor on the long term, especially for chronic reactions such as depression or post-traumatic stress disorder. The children and the young people, it's also population with of concern with the lockdown and the social isolation, homeschooling, also a number of aspects in relation to the risk for abuse, that maybe we will be aware after confinement when children go back to school outside the family environment. The women have been exposed frontline both at home and at work, many being a social worker or nurses. And the COVID-19 survivors, that's another population. And recently, we know that this population may be at risk of developing neurological and psychiatric disorders for different reasons that could be also of biological nature. So the child and adolescent psychiatry, I would like to pause here because all the indicators of childhood have declined. And the mental health of our children is at the moment quite worrying, and there is a number of manifestations that we can see as well in adults, such as anxiety, depression, suicidal ideation and behavior, but also other type of manifestations that are maybe more specific to children and adolescents, such as addiction to screens, and fear of going outside, and as I said a bit before, domestic violence and has increased during confinement and lockdown phases, and the risk of abuse for children also. So the long term of this mental health crisis in relation to the COVID-19 pandemic is still not known. So in psychiatry, it's not like in pandemic, it's do not effect on the long term. We will not have this bell curve, that we can observe. And the risk is, on the contrary, that the consequences of the COVID-19 are getting deeper and deeper, and most are probably still ahead of us. Again, I mean, we can expect an increase in depressive disorders, anxiety disorder, post-traumatic stress, and addiction. And another aspect which is quite important is the consequences on the patient with mental health disorders on the care interruption due to the lockdown and the pandemic, and many have been lost to follow-up, and this will have also an impact on their care once the pandemic is over. So what we could do at EU level? So what we need most certainly is to have a system in place to get accurate and comparable data at European level. We have seen a number of studies that are all pointing toward the same direction, so an increased risk, but we need to ensure that the data we have are compatible and they use a methodology as much as possible, so we can really have a comprehensive and accurate picture of the situation. What could be done as well is a survey, for example, to measure the impact of the health crisis on the quality of life and the mental state in the population, and focusing maybe on vulnerable groups as we have just presented. Another action, and maybe something that we can think all together, is how to synchronize national vaccination strategy. We know that the people with mental disorders are more likely to get the COVID, and they are more likely to die from it. So in terms of vaccination policy and groups that are of the priority, this is something also that we could think about. And very important aspect is that if we want to be able to detect early the reaction and to prevent as much as possible this psychological, psychiatric reactions to occur, we need to have a better system in place and to work together towards less stigmatization of patients with mental health disorders. We know that these patients are stigmatized already. And during the COVID, if we want to avoid to have too many lost to follow up or too many people underdiagnosed and therefore undertreated, we really need to ensure that preventive measures are in place and there is enough awareness on this risk in the population. We know that the later we wait and the harder it will be to treat these patients. So another aspect I wanted to talk to you this morning about is the psychiatric health system overhaul. We know it's been under a lot of pressure already before the crisis. The crisis has widened the gap even further between what can be offered and the demand. And what we have seen, and we discussed this morning already, is access to care. And we want to ensure that it's equal and it's enough. Mapping of psychiatric sectors throughout Europe to have a better idea of the situation, where are the needs, what could be done to ensure that people are treated as they should be. So both in the short term or also in the long term. So short term, we have seen that in several member states already, but it's opening consultation centers dedicated to COVID-19 related mental issues. And in the long term, we need to think at how we can increase the capacity of the whole system and to build more community-based services so we can handle also the long-term issues of the COVID-19. So here I mentioned as well that more training is needed so we can have also more healthcare professionals. That's not a new issue, but the COVID has certainly not helped in this regard. So overall, and just to finish really the advantages of a coordinated action, first of all, to have a comprehensive picture of the situation, then to identify urgent and long-term needs in mental health area, to monitor the situation. If we know what's going on better, we can also monitor both short-term and long-term. And we can also advise on strategy to be implemented where there is a need, and also assess afterwards the effect of any policies that we could be put in place. Also, another aspect is if we have a better idea of the type of reaction and of what really would be helpful, we can advise on future research and also on guidelines in mental health area to try to really help where it's needed. And the last point, which is quite important, is to be better prepared in case of any future crisis affecting severely the people and the well-being overall of the population. So just to finish, I'd like to say that as we knew already, and psychiatrists know quite well, the crisis has shown that there is a continuity between physical and mental health. And mental health is really a key element of our overall health. And now it's also really a key element of the resilience of our societies in post-COVID Europe. Thank you very much for your attention, and I'm happy to participate in any discussion later.
Thank you, Florence. Very interesting. And as you said, definitely we lack a little bit of more sharing the European point of view for the vaccines. In a recent publication, Julian results showed that there was only a couple of European countries really proposing that patients with mental disorders are a priority for the vaccine. So we have margin of progress. Thank you. Next presentation from Andrew Biddlebank is harmonization of data on professional standards for psychiatrists in Europe from the UEMS. So Andrew, thank you very much.
Great. Good morning, everybody, and thank you for this invitation for me to share with you some of the work that we've been doing in the European Union of Medical Specialists section of psychiatry to raise standards of training in psychiatry in Europe. And this is an important topic, not least because our service users really deserve the best standards of professionalism within their the people who work for them. But also we know there is in healthcare services a very strong link between the quality of education and training provided by an institution and the outcomes that the patients of that healthcare institution can expect to have from their care. I've got nothing to disclose in relevance to this talk today. I'm going to say, first of all, a little bit about the purpose of UEMS and how we work within a standard setting. And then I'll share with you some of the problems that there are with regard to that, and introduce you to a model from organizational science, which might illustrate some examples of a way forward for us so that we can increase standards further. We come from the project around harmonization, and this relates to the free movement of labor, services, goods and capital around Europe that has been part of the European project now for many decades. And the task of setting standards for psychiatric education and medical education, at least in the postgraduate field, is been delegated to the UEMS by the structures of Europe. Within UEMS, there is a council that's composed of delegates from the national medical professional associations around Europe. And within the structure, each medical specialty has its own section with a degree of autonomy about how it sets its business, but it reports to the UEMS Council, which ultimately approves its work. Psychiatry is one of the 50 or so different specialties recognized by UEMS, and we've identified our vision and mission as being these areas about raising the standards of healthcare for people who have mental illnesses, and doing that through setting standards for excellence in psychiatric education and training, and monitoring those standards when we're invited to do so. And we do this in a consultative kind of framework involving delegates from all the member states, observer states also, and we work closely in collaboration with European organizations that represent people who use services and people who care for them. So a lot of our work is done in consultation with GAMI in Europe and with UFAMI. And we've produced two main pieces of work that are relevant to this project. The first is the training requirements for the specialty of psychiatry. And the second is a competency-based training framework around psychiatry. The structure for the training requirements is set down by the Council of UEMS and is common to all medical specialties. So each of the training requirement documents for each medical specialty has these 4 sections within it, and we make explicit within those sections what's expected. So we describe within the document who is recognized to be a trainee within psychiatry, what qualifications they need to enter psychiatric training, and what things they must attain at the end of their training. We talk about how training is organized into rotations that are managed and coordinated. And how those training rotations fit together and organize the experience that's essential to produce the capabilities of a competent psychiatrist. We talk about who can be recognized to be a trainer of psychiatrists, how those trainers may be supported and resourced through their own ongoing training, as well as time given and recognition for the importance of training within their work plans. And finally, the document talks about what each training institution should provide, both in terms of facilities and infrastructure, but also in terms of quality assurance and quality control mechanisms, so that there's an ongoing monitoring of what happens and how the training can be improved. The other main document that we've developed is the European Framework for Competencies in Psychiatry. And again, this was developed through an iterative process of consultation involving our stakeholders, our member associations, as well as UFAMI and GAMIAN. And not surprisingly, it therefore places great emphasis on developing psychiatrists' skills in the domains not just of technical expertise, but also in human expertise. So communication skills and skills that are necessary in involving patients and carers as partners in the treatment process. And that document and these documents have been around for a little while. And together with our colleagues in the European Federation of Psychiatric Trainees, we've looked at how much impact these documents have had. And it's quite striking how there's a variable degree of impact, some countries taking up the standards quite avidly and others less so. So it leaves us with a challenge as how we improve the impact of these documents going forwards. And in considering the problem, if you will, of how we improve the impact, my attention has been drawn to work within organizational science. And I'm going to talk a little bit now about a model developed by William Ouchie, who is a professor of management and organizational science in Stanford. Yes?
The best way to share it, your screen, we will see then this model, because it would be, we don't see your slides up to now.
Oh, I beg your pardon.
No, it's okay, because that was very clear. We didn't need, in fact, the image background, but if you propose a very difficult model, it would be nice to have a look. Thank you.
Okay. Right.
Perfect.
Are you seeing that now?
Yes.
I will play from the current slide. And what Ouchie's developed is a three-approach model to the understanding the problem of cooperation within human systems. And he's identified these three particular areas: bureaucracies, markets, and clans. And he argues that they're not seen in pure forms, but usually seen as combinations of different things. Bureaucracies are characterized by having highly formalized structures of regulation and standards, which are monitored by a formal authority, which is able to give reward or apply sanction. And very clearly, the instruments that we use, the training requirements for psychiatry and the competency-based training framework, have many of those features of standards. What we don't have is a formal authority that can apply either reward for achieving those standards or sanction when those standards are not met. The second approach that Auchi suggests is one based upon markets, where there's values are assigned, where prices are given, and there's balances of input, demand, and output. But in order for that to work successfully, there needs to be a balance between those who supply and those who buy what's going on, and a shared knowledge of what constitutes good value. Within European psychiatric training, we've applied some of this to the initiative of the European Federation of Psychiatric Trainees Test Your Own Training program, which seeks to, if you will, provide a TripAdvisor consumer experience of training in particular settings, in particular programs, and assign a score to each program as to how many of the European standards it's meeting. And that has had some value. But as we know, there are many reasons other than training excellence whereby a trainee chooses the training program that they go to. So that a marketization approach is only a partial solution to the problem. Auchi's third approach is what he termed clan control, and that's a very highly socialized form of control, where identification with shared values is very much to the fore, and the model he's chosen is that of the Scottish families' high degree of identification and alliance with the symbols and culture of what they're doing. Very much a self-regulating approach. And there's possibilities here for us to apply it through some new tools that are emerging, the European Training Assessment Programme, and a proposed European board examination in psychiatry. The European Training Assessment Programme has been developed by our colleagues in radiology and is a methodology for assessing the quality of a training that's delivered in a setting, in a centre. And it allows a rating to be given, a silver, gold, and platinum rating. It's entirely voluntary, but those who get the highest ratings can be extremely proud of those. And it seeks to improve the standards of training throughout the specialty. And the second suggestion that's coming forward is to develop a voluntary European board examination in psychiatry, which allows each individual practitioner to demonstrate their knowledge and skill in our subject by attaining the European board examination. So there we go. There's the problem of raising standards and some suggestions as to how we might do that within our field. Thank you very much.
Thank you, Andrew. Very refreshing, and we will have time for discussion at the end for how you see that implementing new types of assessment should be part of the training in Europe, and that would be very interesting. So we will conclude this first part of the morning by two pillars of the EPA board members, Miriam Schuler-Usak and Martina Roshnik, who are in charge of important aspects of European Psychiatric Association activities. And we will begin by Miriam. Miriam, thank you very much.
Thank you very much for the invitation and a very nice introduction. I'm very happy to share with you our project on geography of mental health care in Europe, mapping psychiatry in Europe. So I do not have anything to disclosure. The objective of our mapping project is to create a database on mental health care data and practices in different European countries in national and international level. And our rationales are, for example, that there is a lack of accurate data about psychiatry in Europe, mental health care in Europe, and there is a need for consistency when delivering key messages about psychiatry and mental health care. And there is a need for robust data, not only national, but also in European level, accurate and comparable data. Our methodology which we use for example, identification of key variables, parameters for these data collection, and we started to collect data, for example, using external resources, for example, publications of WHO, OECD, Eurostat, and so on, and of course, internal resources with the help of our EPA Council of NPAs. And the first step is designing, for example, infographics and later dynamic interactive online tool. The first variables on which we agreed were, for example, basic variables like psychiatrists in Europe, psychiatrist to patient ratio, psychiatric beds in Europe, psychiatric hospitals in Europe. And starting with collecting these data, we were faced with a lot of challenges. For example, we found differences in reportings, differences in used methodological issues, but also lack of figures, lack of facts, and so on. And we found that not all data which we could collect reflect the current situation, actual situation in national levels. We also learned from others, for example, from European Society of Cardiology. They have really very nice mapping examples, and also from the European Academy of Neurology, to mention a few of these other associations. And we started to implement a task force group. And in this task group, we have also the chair and co-chair of the Council of NPAs, and we, the task force analyzed and agreed also on a basic variables which were forwarded to the NPAs with the question or with request to collect data. And we have also a first pilot phase till the end of 2020, till when we wanted to collect some basic data and then elaborate infographics, but we are still in progress, and that means that our project is a work in progress, and the results which we till now collected are not ready, and thus I can't show you now some infographics because we are in progress. Our timeline 2020, I already reported it. 2021, we will finalize these infographics and publish them. And we know that some countries may not be in a possession of certain data, hence some of the criteria may not be comprehensive for all selected countries. A disclosure will be provided in the database. And going on, 2022, we will implement our interactive online map, then the information digitally transformed and accessible. We have a very nice software for this program. Our action plan looks like that we will go on with evaluation and validation of collected data, of course, with the support of the NPAs, and we will create, as mentioned before, this interactive platform online, not only till 2022. This is an ongoing process, so it will be updated in a regular manner. We also started cooperating with the Ambassador Project. We have a pool of participants, and we can develop also with their help maps. And our task force and the Ambassador Project representatives have worked together to identify relevant variables in the field of the role of patients in the decision-making process related to mental health care. So this is the survey which is presented during the EPA Forum, for example. And by the end of my short presentation of mapping in Europe, European psychiatry, I will point out that mapping of psychiatry is a part of the EPA long-term goals and visions. Thank you very much for your attention.
Thank you very much, Miriam. Let's go directly now to Martina. Dr. Wojnik, who's in charge of the ambassador, as you saw linked to this previous one. Thank you, Martina. Perfect.
Mute. Okay. Good morning again. It's my pleasure to present you the results of the first ambassador survey. The survey was done by the European Psychiatric Association in conjunction with the national societies. I was the board member who was in charge for the project, and I have nothing to disclose. The idea behind this creation of the ambassador project was actually to build a pool of psychiatrists who would be able to provide input on different topics of mental health, which would be of interest in a certain time point. And since there was a crisis of the beginning of the pandemic 19 in Europe, we decided to build our first survey on the changes of mental health which occurred in Europe during the first wave of the COVID pandemic. The first survey was done in around July 2020, and we recruited all participants at the forum, participants at the European Congress, EPA members, and members of the National Congress, the National Council of National Associations. And this first survey actually was based on the situation in Europe in April 2020, because the most of the Europe were at that point were at the beginning of the lockdown. So for this survey, we had 940 responses that were collected. About 40% of participants were female, participants were male, and up to 40 participants were early career psychiatrists, the rest were senior psychiatrists. I would like really to show you 3 points from this survey. The first was the number of cases, which we wanted to see whether there was a drop in the number of cases in April 2020 comparison with the previous period. And what we really found is that the cases dropped to about a third of the previous period when it comes to April 2020. As for the second point, we wanted to see how many of the services switched to online. And you can see here that in Europe, from 25 to 75% of services switched to online, depending really on the country. And for the third, we wanted to see what was the predominant model of care, which means that we asked if a patient had mental health problems and had also COVID, where the patient would be treated. And you can see here that there were different models. For example, in some countries, those patients will be treated in COVID facilities for all patients, where in some countries, in major European countries, actually patients will be treated in mental health hospitals who had developed departments for COVID-19 states. As an outcome, one of the outcomes was actually this EPA policy paper, which is now submitted to European Psychiatry. It is under revision, but also we wanted to distribute all the data also to some circles which are not strictly psychiatric. So we had this interview for the Syria, which is a non-profit newsroom based in Spain. As for the other part, we decided that Ambassador Project would be a part of the long-term EPA or long-term goals and vision, and also to link it, as Miriam said, to the mapping project, as to maintain it and link it to the forum activities. I would like here to say really that two things which are maybe important for this project. We saw here the data from different countries. However, the way how the project and how this project is really surveyed, how it's done, the data that are gathered are not representative for the countries when we compare one country to another. But they do really present a picture of what is happening in Europe, and then can be used to form an opinion or suggestion for what is important and what should be the direction that we should really be taking. But secondly, I would like to say that another point is very important. When it comes to different data from mental health, we have this data measured from several major European countries. Whereas for the majority of countries, we have virtually no data at all. So this is really a way how we can gather data for all European countries. But this is also a way how the European countries can contribute and shape really the policy which are of relevance in Europe. I would like to Thank you to all those who contributed to the first survey. Here are the presidents of all national associations. They contributed to the first survey, but also to the shaping of the paper. To Professor Simal Lahib, who was distributing the survey, to Professor Philip Gord, who is really the mastermind behind it, also to early career psychiatrists, and Mariana Pineda-Costa, who distributed the survey to early career psychiatrists. Finally, I would like to invite you to the Ambassador Survey 2021. This survey focuses on the decision-making styles in mental health practices and care, but really what we are interested in is assessing the level of the patient involvement when it comes to evaluation of the quality of care. So here I would like to really invite you to give 10 minutes of your time and to fill the survey, to be an active member of the EPA and also to be an active representative of your country, because the more data we have, the more correct data that we have, the stronger argument we make and pose before the EPA policymaker and before EPA cooperation here. So we will have the time of 10 minutes to link the survey during the interactive pause. Thank you very much for your attention.
Thank you to both of you for your incredible energy. And this is really two very important development of the EPA, which are really relying on your energy and capacity. So that's really great. Thank you very much. So you've been, all of you, really nearly on time. So that's really great. We have some time for discussion. We can start by some of them that I picked up within the different questions. The first one was mentioned by Stefan de Souza, asking about this idea about the increase of suicide, probably raised by Florence in the EMEA presentation, where we heard about increase, sometimes also decreased rates of suicide during the crisis. Could we have some more clear idea about what is exactly the relationship between the suicidal risk, behavior, death, and the COVID crisis?
Yes, thank you very much for the question. So indeed, I mean, as you've clearly said, I mean, there are some studies who are pointing toward an increased risk, and I think it's maybe more clear for the young population, and also after the lockdown phases. And it depends also on the type of studies, and some have shown also that it's not that substantially increased. So I think we really need to understand more which population are the most at risk, and what kind of suicidal ideation and behavior they have been presenting, because can be ideation, can be a proper attempt. So that's why I go back again to the idea that we need to have more epidemiological data. That's not a new thing in psychiatry, but in the COVID crisis, I think it will help to have a comprehensive picture of the situation, country-wise, population-wise, symptomatology-wise.
Thank you, Florence. And definitely what was difficult is that with the confinement, we had a lower access to care, so probably also reduced capacity to detect those problems. Question now to Catherine about, you heard the presentation from John Ryan saying that they're so keen on the quality of indicators. Quality is one aspect, but at the OECD, I know how you want to reflect all the different aspects. How are you going to manage those two relatively different angles?
Yes, thank you. Of course, that's one of many considerations. And so I think that's why we try to really report on a constellation of indicators to give a full perspective of the status of quality of mental health services. So looking at some of the structural measures, access to resources, but also how we interpret those in conjunction with health outcomes and our newer measures of patient-reported indicators. The patient-reported indicators are still in their pilot phases, so we know that they're not going to be as reliable and harmonized across countries as some of our more mature indicators. But we're really seeing it as the first step is that we get everyone on the same page in collecting and reporting this data, and we continue to work to refine the methodologies.
Thank you very much. There's another question for Dan, because you showed that there are so many different angles, different stakeholders in this aspect of changing a little bit how we assess quality of care. How do you see the difficulty of, finding overlaps and common features that might lead to concrete, use of specific markers and indicators of quality of care? How should we cope with all those different angles?
Well, having discussions like this definitely helps. That's for sure. I think, as I was mentioning in the beginning of my presentation, I think it's a question of determining what you want data and indicators for, and that sometimes, it seems an obvious question, but I think it's not always addressed. But also, I mean, there is a very obvious risk of duplication of data. And I forget which presenter earlier was sort of alluding to that the fact that you have inconsistent data coming from different sources. And part of that is for a good reason. Maybe there are, good reasons why there are slight differences in defining services, for example. What do you mean by, outpatient care, for example? So that, but on the other hand, there's also the reliability of data, and we have a big problem sometimes, in seeing, massive changes, implausible changes in, for example, number of psychiatric hospitals between 2014 and 2017. And then that ends up casting some doubt on the WHO, on the quality of the WHO Atlas data. So we spend more and more time, trying to sort of validate and go back to countries to do that. But I think, to get back to your question, I mean, I think there is, a clear need for synergy. So for example, when we were planning the Atlas 2020, we invite Emily, in fact, not Catherine, but from OECD to participate in that. And likewise, we participate in the OECD's work on benchmarking for mental health, which is very valuable. And I think the work on the patient-reported outcomes is tremendously important, because it's basically filling a gap that has been out there. So I think that's something to really focus on, and maybe for different parties to get around, because until we can really demonstrate as a sector that we're really good for the business, that's always going to have an effect on prioritization, allocation of resources, and so on. So it would be wonderful to have concerted, comparable data on this dimension of the data spectrum. Thanks.
Thank you. Definitely collaborating together would be the best way to do that. So there's a last question I have directly to Andrew about the training aspect, which is, of course, so important. It means if we really want to include this new trend of really relying on patient's angle, instead of what we did before, only about our instruments and quality of diagnosis improvement, it means we need to include that in the learning process. In the how do you see that? Because it's always takes time to propose these guidelines and proposals. How would you see implementing this type of a new angle?
Yes, thanks for that question. There is an old adage that people respect what you inspect, and behaviors change when you focus attention upon them, and I would therefore think it's very important that we look at what each practitioner does, and we look at what each service does, and how each service and practitioner seek to incorporate the viewpoint of the patient and the carer in what they do. In medical education, there is now a really strong evidence base that practitioners who explicitly incorporate the patient's viewpoint and explore the patient's viewpoint very clearly actually get better outcomes with their patients. And what's really interesting for us in psychiatry, I think, is that there's strong evidence that practitioners who do that find that their patients will follow their recommendations much more, even when the patient doesn't necessarily agree with what the practitioner is putting forward. So the idea of exploring the patient's perspective is absolutely important to outcome. It's important to quality of service. And I suspect it will happen more and more as we explicitly ask questions about it through examining individual practitioners and by looking at the practices that go on within each service. So I think examination and inspection are really important to achieving that.
And in this idea, do you see that the EPA could be a little bit helpful in this regard?
Well, that's a leading question, isn't it? To which only one answer is, but yeah, absolutely. We, as a species, human beings, we do things much more effectively when we do them in collaboration with each other and across a range of stakeholders, national psychiatric associations, as well, and importantly, as those organizations that represent people who use mental health services. We have to build these broad alliances. Nobody's actually yet mentioned the proposition by European parliamentarians to have a European Year of Mental Health. And as some of us around the table know, there is a lot of discussion going on led by MEP Maria Walsh to look at having a European Year for Mental Health with the strapline that mental health is everybody's business. And I think initiatives like that are also really, really important. I know the EPA is active in that initiative as well. And I think if we, the more we collaborate in ventures like that, the more we will bring about improvements in what we're seeking to deliver.
So a leading question, but a leading remark also. It's a pleasure to work with the UMS. We are really, really happy to be aside of you to help for this passport of what is a psychiatrist in Europe. So thank you very much for that. We have a very interesting question from Kimo Swakas about the indicators of equity in access to care during a crisis, a complex issue because we all know how it is important. Who would be interested to reply? Because all of you could in fact have an idea and show some ideas on the equity to access to care during the crisis. How could we find good indicators and then being more able to try to improve them later on? Okay, everybody's thinking deeply, but if I can have some ideas, I mean, there's no problem with sharing your ideas.
I think, Philip, if I could share an idea, and it's more a caution. Sometimes one of the things we do is we measure things that are easy to measure, and we don't look at the things that are more difficult to measure. And it may be that those latter things are actually much more important. You know, we can measure numbers of people who are admitted to psychiatric hospitals. We can measure how many people have symptomatic improvements, but actually starting to explore the things, other things that really matter will demand effort. So I think my note of caution is to, yes, we must do this, but we must do this really thoroughly and really imaginatively and measure the things that are difficult.
If I may add something
Please.
as well. Yes. No, it's just to come back also to your previous comment, Philip, that we are in a period where it's difficult to reach on to people. So also in one on my slide, I suggested for discussion as well, this, and it's already out there, to try to reach people also via a survey, other means of communication, other type of sources that, as you have rightly pointed out, they may not go to the ward because maybe, you know, the ward is quite busy with, unfortunately, that the situation with other medical urgencies due to the COVID. So creative manner would be also to use different sources to reach out to our patients, and the digital tools, as are not accessible to everyone, that's another problem, and it can create another type of inequity. But I think we need to multiply the sources and be creative. So if the patient does not come to the psychiatrist, the psychiatrist has to go to the patients one way or the other. Thank you.
Thank you. Thank you for this remark. There's another question from Karina Konstantinova. What about using the number of incarcerated persons with mental health issues as an indicator? Maybe Catherine or Dan and both of you could give your idea? You know, that's an interesting point about those getting to jail. If the frequency of how many have psychiatric disorders treated or not might be an indicator. What's your opinion on that, Catherine?
Yeah, that's an interesting proposal, and it's definitely one that encompasses some of the cross-sectoral challenges of creating indicators that really assess the outcomes that we're looking at. To be quite blunt, my answer is I'm not sure. That seems that is something that I'm sure that I have colleagues, especially working on the impacts of mental health on productivity and on other sectors that they might know more of, and if there's been any work done to collect this information in an internationally standardized way. But to be quite honest, I'm not sure if that's been something that's been looked at the OECD.
Sure. It's a relatively narrow topic, but always interesting. Maybe Dan?
I was going to say the same. It's very specific. You know, I think we run quickly into some problems of consistency of data collection. We're talking about international, you know, comparable data collection exercise there. But of course, I mean, and what is it exactly an indicator of? I'm not sure it's a very strong indicator of the quality of an overall mental health system, for example. So yeah, it's back to the question of for those working in that particular, that I think it could be of great use and interest, just like, you know, for getting, for example, better information on children and adolescents, you know, which was alluded to earlier. Just on the previous question, I think, yeah, I very much agree with Florence's point about when we're talking about access to services. You know, basically the way to measure that is through population surveys. There's been a bewildering, astounding number of surveys undertaken over the last year looking at different aspects of COVID, including information on this question. But I think the bottom line is that the pandemic has deepened or exacerbated existing inequalities. And so people who are already at higher risk and more vulnerable have had their opportunities for access reduced over the year. And with all the move to remote forms, modalities of support and care, people without access to internet, or maybe with cognitive disabilities, intellectual disabilities, they've been further, isolated in that sense. So I think surveys will demonstrate a widening of the already existing inequalities.
Very good. So we are exactly on time for a 4 minutes break. Miriam, if you have a remark, but very quickly, please.
Yes, I think another indicator is, for example, the acceptance of vaccination in different vulnerable groups or in the population in different country levels and so on. And another issue could be also the impact of COVID-19, for example, in different parts of medical system, for somatic, but also mental health issues and so on, or close of beds or wards and so on, could be also very basic or indicators.
Yeah, thank you, Miriam. Definitely, with so many aspects that we have to tackle with this indicator that it is very complex. So we will give you 4 minutes for bio break, and we will give back the floor to Peter on time. Let me just show you, share with you the slide about, if I find it, the link for the forum. You should see it now. Is it, you see it? So that's one slide with the link with the SurveyMonkey, where you have this ambassador type of survey. So we already had some results, and I will show you some just afterwards. But for now, if you are interested to know what is your shared decision style, and if you think that this is interesting and important, please fill it in. As a clinician, we would love to have as many responses as possible, then allowing us to compare the different stars according to countries and also the type of activity that you have. So please take 4 minutes bio break, grab another cup of coffee, and come back in 3 or 4 minutes so that we can continue. And thank you so much for all the speakers of this morning. It was absolutely fantastic.
So thank you very much once more. Thank you for Philip for leading us through part 1 and part 2. Now I have the third privilege to chair the third session on quality indicators of care, proms and prems. Now we take the stakeholder perspective. And I'd like to give the floor to Urs Wirsch. He is the new EUFAMI president. Urs, welcome.
Thank you very much. Hello, everybody. Being representing EUFAMI, I can tell you that we were founded in 1992 and we represent approximately 25 million families in Europe. We have 33 member organizations in 23 countries. Our mission is to represent all family members of persons affected by severe mental illness at European level so that their rights and interests are protected and promoted. We, the families or the representative of the families and the carers, listen to the families. You have to realize that families, long before a doctor sees a patient, are confronted with the situation that the patient is in without really knowing what is going on. That is a big burden on the family and they do not know how to cope. So normally they come to us being regional, local or country-wise organizations. Secondly, once the patient is convinced that he should accept professional help, again, the families come into the point because normally the patient is not ready to see this by himself. Using force is not the right way. So let us help support families to know how they can react in order to convince the patient to accept professional help. Families should also be taken into account when the treatment begins, even though we are well aware that families sometimes may be the cause of a not so good situation. However, they know the person who is involved. And most importantly, after the treatment is over, families are back into the picture because many times the patient has no other way to go other than at his home or to his friends. And again, the stress starts again. So we believe that training families on how to cope with such a situation is very helpful to the total system and helps the health cost coming down. We at EUFAMI do this. We train families and we also like to help the doctors assist us, the nurses assist us. So it should be a good thing to work together. Thank you EPA for supporting us, for understanding our needs, and thank you for listening to EUFAMI.
Urs, thank you very much for this clear message. It is good to have you on board, and now you are on board following, and I can continue to introduce Stacy Yegmononos from Eurocarers. Please, Stacy.
Thanks, Emilian, and good morning, everyone. First of all, I'd like to thank EPA for your very kind invitation, and I'm delighted to see carers involved in this discussion, important discussion. So I work for an organization called Eurocarers. We are based in Brussels, but we are actually an umbrella organization along the lines of EUFAMI. So our network currently brings together 73 organizations from 26 countries. They provide direct services to informal carers, but they're also involved in research on care and caring. And and I should probably clarify that we do not specialize in mental health. Actually, we focus on all types of informal carers, irrespective of the care needs of the care recipient. Having said that, many of our member organizations obviously focus on mental health. And from our perspective, there are two ways of approaching informal care in the context of mental health needs. First of all, informal carers are the main providers of all long-term care in Europe. And along the lines, again, building on what my colleague from EUFAMI was saying, this is important to bear in mind, obviously, because very often informal carers are completely overlooked. They're not part of the conversation, they're not consulted. And so in that regard, there's probably a lot of room for maneuver and improvement in terms of strengthening the interface between care professionals and informal carers, who play a central role in prevention, in adherence to treatment, in hospital discharge, for example. And so from our perspective, informal carers should really be considered or acknowledged as what they are, that is a key partner in the provision of care. That's the first aspect. The second aspect is that there's also extensive research showing that when not adequately supported, informal carers actually a vulnerable group. They're at risk of experiencing themselves mental health issues. So just to illustrate this, the prevalence of mental health issues among non-working carers is 20% higher than among non-carers. So being a carer is a risk factor for mental health issues in terms of anxiety, depression, feeling of isolation. Now, obviously, COVID was mentioned several times this morning already. I cannot help but obviously say a few words about that, because the crisis, the pandemic, has done nothing but exacerbate the pre-existing challenges facing carers. We, as part of our work, are in the process of finalizing a report emerging from a survey, an EU-wide survey we've carried out on the impact of COVID on carers, with about 2,500 responses. And it is already clear, so the report should be published in the coming days, but it's already clear that in terms of the mental health impact on carers, it's huge. About 70% of respondents state that their mental health, well-being, state of mind is being negatively affected by the crisis. So from our perspective in that regard as well, caring, plus the crisis, the pandemic, they amount to a time bomb in terms of mental health for carers. I was slightly disappointed that carers were not mentioned as a vulnerable group in the presentation by the representative of EMA. I suspect probably the study did not capture the needs of carers, but that's a perfect example of what needs to change, including on the side of the Commission. Carers should be considered as key actors in the provision of care, and so obviously in our work we'll continue to push to draw the attention of more and more people. And I suppose my key message for you this morning is, in the development of your indicators regarding the quality of care, please don't forget carers and the perspective of carers. So get them involved in the discussion. Thanks a million again for your kind invitation, and looking forward to the questions.
Thank you very much. Good basis for further discussions. Thank you for the clear message. Now I'd like to give on to Dr. Raluca Nica. She comes from Gamium Europe, and she will present her speech. Please, Raluca.
Okay.
Yep, we see the slides, fine.
Okay.
Yep.
Good morning, and I'm Raluca Nica, and this morning I have the honor to represent Gamium Europe, and Gamium stands for a General Alliance for Mental Illness Advocacy Network. We are a pan-European organization representing 47 organizations all over Europe.
Could you just go down to the presenter mode so then we see the slide bigger? Just
okay. I'll try, but somehow.
This is the little where you see the quadrate.
Yeah. No problem. Here we are.
Thanks. Sorry for interrupting.
No problem. Thank you. So I have no disclosures with regards to these conferences, and indeed I enjoyed the first part of our forum because I heard very good presentations, and somehow many of them mentioned our point of view, namely how to involve the patients in evaluating the quality of the service they receive, and obviously in this way improving the quality indicators. Usually, you know, collecting data is done through questionnaires with regards to the treatment process, but not only, and obviously good questionnaires bring good quality data. So that we can look to maybe two sides to the format of the questionnaire. Very often I met questionnaires which are awfully long and done in a very difficult language, so that many times patients you know, give up somewhere in the middle of them or even quit clear. And the second part that it's also really important, it's about the content, what kind of indicators the patients would be interested to see improving. Of course, we would like to see services that are universal and accessible, and in these terms, we look to the affordability of mental health services because, as we mentioned, probably this is not the case all over European Union. Sometimes the geographic accessibility it's pretty difficult. Patients have to travel hundreds of kilometers in order to get a service, and how timeliness and responsiveness of mental health services is better serving the interest of the patient. Because as we know, there is a shortage of professionals, and sometimes in order to get an appointment, you have to wait for months. Also, how comprehensive and community-oriented is the mental health system of care. And this includes questions about the mental health promotion and disease prevention programs, which unfortunately are happening in very few countries. How do we deal with acute care? Do we have enough institutional care and professionals so that we can offer very rapid acute care and quality acute care? And do we have this community orientation? Community mental health things are really important, and this is a concept that is not covered all over Europe. The chronic care and the community team care is really recovery oriented because very often this is not exactly the concept we find in the community care. We go to professionals, and we do have a shortage of professionals, of all kinds of professionals, and we look to the composition of the multidisciplinary team because we know that psychiatrists are rare, and only 2% of those who are graduating medicine are choosing this profession. So we should do something in better planning of human resources in mental health, and we should also increase the quality of the education they have, because we do need a quality diagnosis and treatment in chronic care, but also in child in mental health care, because we often forget that 50% of the diagnosis happen before the 18 years of age. So unfortunately, there aren't that many people specializing in this area. How the care is coordinating, because obviously people go from one level of system to another, and is it really a coordination between the primary and secondary care? Is the data shared? Are protocols for patients with chronic conditions in place? Because I discovered that very few countries do have really good protocols for chronic care. And we should not forget that most of the patients with psychiatric problems do need social care. how is this coordinated between the two systems? And yes, we do need policies for respite care, very few countries having one. The continuity of care is there in place in different aspects, being it longitudinal or regarding the informational and the relational part. How do we provide these services throughout the life cycle? Because yes, we start in the childhood, but how do we go over to the adulthood period, and what are we able to provide? Is it the care continued until the person feels that that care should not take place anymore? The integration of services suffers very much. There are countries who do have integration of services, and for example, they have mental health services in primary care, Netherlands being a very good example of that. And also they have a good integration between social care and mental health care. Some of the countries have ministries that are called health and social care, which makes the life easier. But very often this integration does not take place. And last but not least, how do we partner with patients? Partner in mental health care planning, because of course it was mentioned several times that the more you involve the patient in the care, the better the adherence to treatment is, and the cooperation and the recovery looks much better. And yes, their opinion is important in the development of mental health services, and we should not forget the informal carers, and the former speaker mentioned, because actually we do have a team, and it's the best idea to use all the members of the teams so that we get the best result. And yes, we should look to the participatory power of patients, because if we do things without having them involved and without having them having a saying in what is delivered to them, then this will not meet their needs, and probably the situation will be much more difficult. Thank you very much. That was my presentation.
Thank you, Raluca, for your clear and very well structured message. So I think we have now the view from three perspectives: Eufami, Eurocarers, and Gamian. And now we come on to the societies. Philip, I have the pleasure to introduce you on behalf of EPA, please.
So do you see the slides?
Yes.
Very good. Very good. It's a pleasure for me. I really enjoyed the presentation already that we had this morning. We would like to focus now on the concept of how the psychiatrist might be impacted with this change. These are my conflict of interest. And so the main idea is that the proms and prems are really about the patient's voice matters. And at the EPA, we're definitely very sensitive to this aspect, as Gamian and Eufami being on board of the association. And this is really interesting, but it has many different angles for which we have to think about and have a deeper understanding of the different meaning. The first one is about the ethical reasons. There's no doubt that we are delivering services to patients so that they get better. But is it better because we think so? Is it better because the patient thinks so? That's a shift which might be very easy to understand. There is also a clinical justification. If we change the angles, usually we discover that some things we did very well, seen in another way, might be, lacking a little bit of performance. And that might be, in fact, for the good and the sake for everyone, of patients, of course, but also for clinicians, because we will find new ways to do things even better. So these perspective is important for the assessment of effectiveness of care, with a more kind of technical look, not just asking questions, but using instruments that will be able to capture the angle of the patient. And that might challenge our idea that what we do is exactly the best way to do it. And that's the advantage of having a different type of approach. One of the way that we did that before was this shift that we did before around 10 years ago, where for schizophrenia, for depression, all the studies were relying on, did I decrease the level of symptoms up to 50% for depression or 20% for schizophrenia so that the patients have a strong relief of the disorder? And that is according to our own instrument. But now that we're shifting to complete remission, no more remaining symptoms, even of the recovery, I'm nearly as I was before the disorder, then we are using other tools, psychosocial functioning, level of well-being, quality of life. And all of those, they are in the hand of patients, not about our eyes looking at how the symptoms might impact their life. So this was already prepared for the last 10 years, I would say. So it's not a surprise that we are now having these instruments more directly connected to this specific angle. What is these aspects that are important for patients for which we might have forgotten the importance of their role in the quality of care we're giving? And for that, with these different prems, we have the, did we devote enough time? We were respectful enough for the patient? Did we involve the patient in all decisions we're taking for their life and their health? All those aspects probably are, of course, part of our interview every day, but focusing on all of them with specific instruments might definitely be an advantage. And in this regard, the development of proms and prems are really promising. This was such a strong message that the OECD decided to focus one of their developments with this idea. Initially, the main points were that at the European level, we lacked common type of assessments that are more in the hands of patients and that should then create opportunities to compare the efficacy of all our systems and then, of course, facilitate the increase of quality everywhere. For that, the OECD immediately made the diagnosis that there were only 5 countries for which proms and prems were really used on a regular basis. And that means for all the other ones, wow, it means a lot of work had to be done. And that was already mentioned by Catherine about the OECD Paris initiative, where all those actors involved in mental health care were joined in a specific meeting in order to find a way to detect which are the best proms and prems we should use, how can that be used everywhere, and then try to implement these activities everywhere. And this point, the EPA was a part of this important discussion, not only to facilitate the links with all national psychiatric associations, but also because we were part of the board as representing patients through our connections with Gamion, who was already there as a major association with this board. So we launched the pilot collection phase for these 7 questions of proms and 4 questions of prems. And I would like to give some very fresh results. I just finished the statistics yesterday on the first analysis we had on the my own department, for which we decided to collect all those proms and prems for patients starting 2 months ago. It's a very preliminary result. We only have 60 patients that we referred and then discharged, for which we are able then to see how many were satisfied or not of their treatment and also of the way they were treated in this. Just give you a couple of results. First of all, the patients are relatively nice. They thought that we were definitely spending time enough, having good courtesy, and that they were involved in this decision. That was a relief, of course, for me, for all our patients. What we also made was that asking the clinician, did you spend enough time with your patient? Because I thought it was really interesting to see the different angles. And what was really impressive is that those ratings are extremely close. So the clinicians usually recognize that there is a lack of time, opportunity, and commitment on both sides. And the discrepancies we found was about the time, where the patient usually were more happy than the clinician. So the clinician has more frustration even than the patients. And when it's about being involved in the decisions, it's the other way around. Clinician says, yes, of course, I am implicating my patient in my decision. But the patient says, oh, a little bit less than you thought. And that, I think, is very interesting. So just to go to quickly, 3 specific results. All the prompts, the outcome gets largely better during hospitalizations, and they have a huge size, which is a large effect size, coincidentally being above 1. There's one exception, the last one from the prompt, which is, my life is rich of plenty of interesting things, for which the level of improvement is a bit lower, and that might raise a lot of very interesting points. The second point, as I said, is that the prompts are very close to the clinician ratings. And the last one, which is even for me even more interesting, is that we've been adding also our everyday instruments, the hospital anxiety and depression scales for depression, the level of ideation of suicide on the other one, and then, for example, the eating disorder inventory in the eating disorder department. So we looked at the improvement of all those scales in the different departments and tried to correlate it to these prompts. And what was surprising is that the level of correlation between these two is extremely small. So the global variance is below 5%. So what we see as clinicians as excellent care, because the patient has much less symptoms, is something completely different from what is the improvement of my life for a patient thanks to this hospitalization. So if there is any question, but you heard this morning a lot that there is definitely some things to dig in, definitely we have a large margin of progress to see how we can see those two angles and see how they are really able to be filled in. The second aspect is for the prompts and prems is one of the aspects of the ambassador this year developed by Martina. We heard it this morning, and we devoted this survey this year to the shared decision style. Are you the one making the decision on your own because you know how to treat your patient? Or are you more about, making a discussion with the patient so that you are really involving the patient in the final decisions? So if you didn't already fill in this ambassador survey, you have here the link, and you have it also in the forum page. So just another aspect of very preliminary results on the very first 115 first clinicians who replied. We have 17% of our clinicians being considered as passive type, which is in fact doctors should take the decision, not really involving the patients as much as needed. And this is what was expected, in fact, and that was the case in the SEDAR study that we used for this instrument. What I really found interesting also that we found no effect of gender of the clinician, the size of the city where they're working, either public or private type of practice, if they are treating outpatients or inpatients, and also the length of practice is not really having any impact on the passive type of shared decision-making. And what we found associated with this time was the cost of your visit, the level of reimbursement, if you act also as a psychotherapist, and if this idea of shared decision-making was or not supported by your institution. So of course, this is very preliminary, and we will have then to look at the different countries that tested it, but I see there already some very nice leverage where we can change the matter looking at those different aspects. So to conclude on my presentation, it's sometimes seen as an elephant in a China shop, because it's such a new approach, and as we said, it is so disconnected to the symptom improvement, so that we might be a little bit awkward when we look at these different aspects. But nevertheless, it is a source of challenge and a nice range of opportunities. But do we have enough time and skills to implement them, and motivation? Because this is the only way to see if we are able to give this capacity to rate to the patient, not only to ourselves. Are there going to be biases, especially for those patients that reject the possibility to fill in the prompts and prems? This is an issue because they are also needed. How does it impact our daily practice understanding, including the patient situations? All the aspects also about the needs might be differences, the perspective that might not be equal from different patients. I like also to raise the point that now with the prompts and prems, we see how it is so important that patients are being treated with courtesy and empathy. And this is, of course, we know, a very important skill for clinicians. but we don't have it really as a proper specific training. That might be something we could work on. How to facilitate patients' informed preferences should be also an important aspect. So we have this pool because we also want to see differences according to countries. And in this regard, we have to understand that how those proms and prems are being rated depends of many different layers. It depends of what is the patient expecting, what is the patient, the clinician delivering, but also the setting, the time, the organization, the type of clinical activity that you have. So all those different layers have to be understood. The local and longitudinal analysis of outcomes should be definitely more important and to be developed later on. So we have to develop these adequate skills for medical students as quickly as possible, and maybe it should be part of the training curriculum, because that would be also reinforcing the capacity to give good care. So substantial expertise and professional authority should be then facilitated. This is my last slide, saying that for the proms and prems, it's a new tool. And with each time we have a new tool, there's plenty of advantages. We have a new language, which will then help us to discover some aspects for which we can definitely make so much progress. But we have to understand those rules and see the procedure before being really active. There's therefore many advantages, but of course, always some pitfalls that we will discover progressively. And in this regard, it's still a work in progress. Thank you very much for your attention.
Thank you very much, Philip, and especially sharing with us your preliminary results. And I have to say that someone commented that has been a brilliant top-down and bottom-up discussion, and I think that's what I would pull together. I think it's a very nice introduction. And so we come to the next society, which is actually the European Federation of Psychologists Association, represented by Professor Steinebach. Please, Christoph, go ahead.
Well, thank you very much, and a warm welcome, and thanks for having me here in this symposium. I'm very glad to be here. I prepared some slides, as you can see, and it's about the value of data, which I would like to cover and discuss a bit. There is nothing to disclose, so I move on. I have to tell about EFPA, representing 350,000 psychologists all over Europe, and it's representing psychologists in 38 European countries, and a lot more to tell about EFPA, but not today. If you ask a psychologist for a clear-cut answer, the answer might be quite often it's difficult. It depends, and it depends because it's complex. The complexity with the perspectives of clients on the services and the therapy has been mentioned earlier in the presentation by our colleagues from WHO and OECD especially. And you see every answer about how you feel might be related to internal systems, individual systems, but also to external environmental systems. And we have to keep in mind that all those systems are in a time process, so they change. And we have, depending on different cultures and societies, we might have absolutely different clusters. And so for this, it's complex. And the complexity is also to be seen when we just focus on the perspective of the clients. We have the health problems, and psychologists discuss the quality of data. Then it's usually about objectivity, reliability, validity, and that is like the discussion in the empirical sciences. But then it's also about being responsible for the research and the process. It's about transparency, and it's about availability. So for us, the movement for pre-registered studies and the open access movement is most important. But the availability of results, of information, also makes it very difficult for a layman just to learn about now what really counts, what are the important information. And we have to keep in mind in this the complexity as well. If we have a look on the risks we are facing, and that is a wonderful picture from World Economic Forum from 2020. And in the upper left corner, you can see infectious diseases. Perhaps this picture might not be different when we face the pandemic. But what we learn is that all the risks, all the problems are in their way interconnected. And on the other hand, if we have a look on the map of science, having a closer look on how scientists are reading and covering the different research results in different sciences, we see that they usually stick to their clusters, to their field, to look for a solution for a problem. So on the one hand, we see risks are connected, and on the other hand, we see that we are usually quite often focusing on our profession, and that can't bring us to the right results in that. What we should strive for, of course, is consilience, meaning that we have to identify the powerful, simple truths. And hopefully, having a look from different perspectives, from psychology, from psychiatry, from many other perspectives, but also especially from clients' perspectives, we might find simple truths which are really helpful for working together to make problems less burdened. So in this way, one point is to clear out, and that is how do we communicate the results? Because clients also need to be informed. And it might be helpful in the future to have more of those clearing houses which try to line out where is the consilience in the different information. And also to give advice for practitioners how to cover prompts and trends, how to look on that, especially what are good questionnaires? How can we do that in different settings in a way that it's not a burden for the clients, but it's really bringing forward the therapy process. So that would be our interest in the future, just a suggestion to have a closer look on so that there is more and clearer advice, because many of our colleagues in practice don't have the time and the energy and the resources to cover all those different aspects to find the best practice. And they really would like to do that best practice. So thank you very much for listening, and I'm looking forward to our discussion. Thank you.
Thank you very much, Christoph. It's very interesting, sort of different view on the same problem. But I mean, looking at the data and thinking about what needs to be done is always good to do the right studies. So very nice. So then to conclude the talks, I'd like to hand over to Claudio Bessetti. He is the president of the European Association of Neurologists. Claudio, the floor is yours.
Thank you very much, Peter. Philip, I do really enjoy this multidisciplinary platform, and I have to acknowledge that I learned a lot. And I read some time ago an interesting article, what neurologists could learn from psychiatrists. I have the impression that we have something to learn from you and from other disciplines. And I liked also the hint to the simple truth of the last talk, and I actually took a picture of your slide, which was very inspiring. So I will come down a little bit more to what we currently do as European Academy, and it may be a little bit more technical, but we feel that this approach is also of interest for the field, and maybe also may help other fields like such as psychiatry, psychology to maybe reflect on similar activities. So I will talk about mapping the burden of neurological disease, and I will report mainly on one or two activities that we have developed recently. No disclosures for this talk. And I should start that as probably most of the fields, we did not have really good data until very recently. And one of the reasons is that the classification that has been used for some of the data analysis were not sufficient or not correct. And I allude here to the ESD10, where stroke was still classified under cardiovascular disease, Alzheimer's disease under mental disorders alone, and brain cancer under cancer. So now some of these misclassifications have been corrected, which obviously are the base then for approaches that that are useful then to measure the burden. The second point is that the methodological differences, were difficult, and we heard about, the discrepancies in data sources and the lack of also an acceptance worldwide led to discrepancies in data sources. So I think the Global Burden of Disease Consortium initiative turned out to be helpful in creating a database that I believe it's well accepted and methodologically sound. There are thousands of scientists that are involved in this initiative. And as you certainly know, there are hundreds of countries that are actively participating. And the analysis actually includes almost 200 countries, probably all countries in the world. This has been funded by the Gates Foundation, and it's actually well accessible by all scientists. So I think this is an incredible source of data that we all should use and share. Now, this led actually in the neurological field to initiatives worldwide, and this has led to multiple publications. I referred now to the most recent one, which actually summarizes the main findings of this approach based on the GBD, 21 disease categories. And we have in this paper, Feigin was the first author, the prevalence, incidence, and disability-adjusted life years as main outcomes. And the main result of this paper was not completely surprising, but in this maybe extent still interesting, that neurological disease turned out to be worldwide the main cause of DALYs, disability-adjusted life years, and the second most important cause of death, accounting for 17% of the entire burden of death. Now, we are in Europe, so Günther Deuschel, who has been my predecessor as EM president, launched an analysis of the global burden of disease in Europe for neurological diseases. This was conducted in 28 EU countries, and some countries that are included in the WHO definition of Euro were also included. So it's a kind of an interesting cut across the different European countries. And the data were similar, although not identical, to the world statistics, in that neurological diseases were found to be the third cause or source of DALYs in Europe, and the third cause of death. Now, I refer to the paper for the multitude of interesting data that were collected and analyzed. In this representation, you see two things. You see on one side the differences between the different countries in Europe, Eastern Europe, Central Europe, and Western Europe. And you see that the source of burden is also different in terms of the disease themselves, stroke being the largest or the most important source of burden for neurological diseases, dementia being the number 2, and migraine and headaches the number 3. But you see that if you look into the different areas of Europe, there are major differences, which I think is also the result of different, obviously, of multiple causes. Now, we do have also the possibility of looking at evolution of DALYs, death, and overall prevalence. This is also a very complex slide. And actually, this is only an extract of an even more complex table. But what you, or what I would point out is that, yes, DALYs and death are decreasing or have been decreasing over the last 30 years in terms of neurological disease, quite significantly, pointing to progresses in diagnosis and treatment, for instance, multiple sclerosis, for instance, stroke units. But because of the aging population, because many of our diseases are still age-related, we have an overall increase in prevalence. So, I mean, what we have improved in terms of diagnosis and treatment availability and treatment is now being counteracted, so to say, by the fact that there is an increased prevalence of neurological diseases. Now, we have the burden. Now we can look at the working force, and I have two slides. This is the representation of how many neurologists we have in Europe as compared to the number of inhabitants of the different 45 European countries that were looked at in this analysis. And you see there is an incredible discrepancy. You probably know that there are not so many neurologists in the UK, but you may not know that there are many neurologists in Georgia, and so on and so forth. And this is the mean number of inhabitants per neurologist. I would be very interested in knowing what is the mean number of inhabitants per neurologist, per psychiatrist in Europe. When we look at the number of patients that a single neurologist has to take care of, this is a second statistic that may be of general interest. It turned out that the average is 10,000, but it goes from up to 50,000 in some countries down to less than 3,000 in other countries. So the burden is very different in the different European countries, and the availability of workforce is very different, and both are not matched. Now, what's about the cost? Well, we do not have really recent data on the costs of neurological disorders. We do have, and this is certainly material that is well known, at least to our colleagues of psychiatry. We have this old study where the cost of brain disorders in Europe was analyzed, I believe, in 27 plus 3 countries. Switzerland is sometimes considered outside Europe, but was included in this analysis, as Iceland and Norway. The overall estimation of this large study was around 800 billion for the entire group of brain disorders, that is neurological and psychiatric disorders. Now, when we try to sort out, dissect what we would consider primarily neurological diseases, well, it turns out that these account for almost half of this entire cost burden in Europe. You see that dementia is the number one, then stroke, headache, sleep disorders, and then you have listed the other diseases which account or contribute to the costs. Now, we do have bad comparison to other non-communicable diseases costs in Europe. So this is an old depiction of the economic burden of brain disorders as compared to, for instance, cancer, diabetes, and cardiovascular diseases. And not surprisingly, this should be known, brain disorders, or one could say neurological and psychiatric disease disorders, are the leading cause of costs in Europe. So I would like to come to the conclusion to tell you that based on recent analysis conducted with the Global Burden of Disease Consortium, we have realized and we have understood that there is a huge burden, an unprecedented burden of neurological disease in Europe. We have, unfortunately, an increasing prevalence because many, if not all our diseases, I'm thinking about Parkinson's disease, I'm thinking about stroke, I'm thinking about many dementia forms, are indeed related to aging. We do have a very broad disparity of available workforce. Some countries have a high density of neurologists, but most countries have an insufficient workforce. And we have an incredible difference in regional burden and available workforce, which actually asks and requires tailored intervention to the different countries. We are active in making funding bodies, policymakers aware of this burden. And we think that the best way to run discussions is to have concrete data. And this is why we have just decided this week to start a new study on the cost of neurological diseases. And obviously, there are many methodological issues, limitations, but also potentialities that we are aware of. And as I said, we just gave the green light for a new study that will look at the cost of neurological diseases across Europe. thank you very much for your attention, and I would be glad to address any questions you may have.
Okay, thank you very much, Claudio. We are a bit short of time, but we will start with the discussions. If you could de-share, so then it's easier for us to see each other. Oops, once more de-share, please. Now we see, you know, everything, your presentation, just de-share if possible. Anyway, I have a look at the, can I have a look at the, no, doesn't work. Look in the chat. Oh yeah, fine, that's fine. Okay, so maybe we start with Florence, because she wanted to clarify or add some evidence to clarify the comments made about the carers. Maybe we start with that. Please, Florence, give us a short.
Yeah, thank you very much. No, just to clarify one point about the carers, it's a very important point and a very important group, of course. And I think it was somehow a bit integrated in my slide, and I went quickly through the different groups. But we know that I think it clicks as well with another point that was made previously about inequity, because I think this has shown as well another inequity, which is a gender one, because so far, I mean, we know worldwide carers are mostly women and young girls, and those people, not only, but it's social workers have been at the front line, social carers, and it's also combined with a difficult access to care. It has put a lot of pressure on those people's shoulders. So thank you very much, and happy to further discuss, obviously, in any other platform. Thank you.
Okay, there is, I think, a question to Christoph from Kimo Suakas. Can you provide good examples of quality data collections in Europe or elsewhere on national level? I mean, how in practice service users best report proms and prems, and how is this data best collected? Any idea, just, or maybe anyone else?
Well, that is the core question, I guess, of our forum today. So how can we reach that, or on the other hand, what is available today? And what I lined out is the difficulty to decide on what is the best and now what to do directly and immediately. And when we take in addition the perspective of the clients, then we see that not all clients like to be asked always about the process and how they feel in this, how they see that. So the valuation of this also is quite differently in different settings. So at this point, as a psychologist, I could say, and I'm sure in the name of our colleagues, there is no easy answer to that. The question in the future will be, where would I get information about that? And how is this information really made clear and in a way formulated so that I can grab it easily? And for that, I think we need more defined points where you can reach, where you can ask, and where you get just that information, which also might be then more clear focused on the field you are in, the clients you are working with, and that you learn about best practice in just getting those information.
Thank you. Are there any questions along these lines or other questions from the speakers? Because I don't have any more in the sort of chat. So if that is not the case, then I would say I'm quickly wrapping up, and maybe then something comes. I think I've learned a lot. I mean, this is something what Claudio, you said, but I think this is always nice about the forum, which is actually introduced by Wolfgang Gabel. And I think that, Philip, I have to say that you wonderfully chosen a topic which really goes to the heart, because it seems to be that is something we can move care. You know, we can move ourselves, and you have shown quite nicely with the data I thought it was important that we introduced Eufami quite quickly, and then that Europe carers and Gamian, if I think about that, you said, what about affordability, geographic availability, and what about time availability? I mean, this is all, being available. These are issues, we need to clarify. It's not that we can increase the resources, but we need to think about where we actually have to sort of go with them. I have learned indeed that you can very, very quickly, because I evidenced that from, night emails from you, Philip, that, the questions were going forth and back, and then immediately having a little study. So what you can actually do within a department, asking, what do we do? And I found it quite impressive to learn that we think that what we do is optimal and that will help the patients. And the patients might think a bit differently what helps them. So I have to take up the idea of today brought by many, that, asking the patient what he might want is the first way to actually deliver good care. And yes, indeed, training of these skills. I mean, this is something we should take up, Philip, maybe in my presidency, continue this idea and, think about how we can train these skills. I liked your talk, Christoph, a lot, just saying, wait a minute, before we go, we need to think about, what is the quality of the data? Where do we get from? And, what do we do with this? And I always like to have on the team different thoughts. Those ones who say we do the scales and we give it to the patient and the clinician, and those ones who say, okay, fine, but let's think. So that's and I have to say, really, I was impressed by you, Claudio, all about the valuable data you have gathered. And I think that at the end, especially when you said, we are starting another study, data are those things you can convince politicians, and you can convince people by saying, well, look, I mean, you don't fund us, but you have a problem here. And I show you, and these are the data. And I think this is more than just talking to people. So I think it is everything, thinking about things, doing studies, and then gathering data in order to fill them up. So I would say that indeed, I think that was a beautiful setup this year. I enjoyed it a lot. I usually enjoy the forums a lot, but this time I have to say I enjoyed it a lot. And I thank all the sort of speakers, all those who contributed with their questions and sort of the communication. And so, Philip, you should have the last word here, because Kenneth will give us a sign that to stop and send people to the next, let's say, thing in the ongoing Congress. Please, Philip. Thank you very much.
Thank you, Peter, for your nice words. I definitely enjoyed it also. I think it's something common here. We are all interested in this new aspect, and so much work is needed. Everybody raised this point, and if we do that all together, that would be probably the best way to go on a consensus about how to do that the most properly as possible. So thank you all for all your participants. It was really nice, a lot of interactions, and I hope that we'll have the rest of the Congress all together. So